ulcer disease. For the first, about gastritis. Gastritis is inflammation of the gastric mucosa. It can be classified as erosive and non-erosive based on the severity of mucosal injury. It can also be classified according to the site of involvement within the stomach, for example, cardia, corpus, or antrum. And gastritis can be classified histologically as acute and chronic based on the inflammatory cell type. For the first, we will talk about acute gastritis, acute erosive gastritis. Causes are drugs, especially non-steroid anti-inflammatory drugs, alcohol, acute stress, as occurs in severely ill patients. Less common causes include radiation, vascular injury, or direct trauma. Acute stress gastritis is a form of erosive gastritis in severely ill patients who have an increased rate of clinically significant upper gastrointestinal hemorrhage from mucosal lesions of the stomach and duodenum. Risk factors include severe burns, central nervous system trauma, sepsis, shock, respiratory failure with mechanical ventilation, hepatic and renal failure. In general, the more critically ill the patient, the higher the risk of clinically significant bleeding. The pathogenesis of acute stress gastritis likely involves decreased mucosal defense mechanisms in a severely ill patient. Symptoms and diagnosis of acute gastritis. Acute catarrhal gastritis is characterized by pains in the epigastric area, dyspeptic syndrome such as nausea, vomiting, sometimes subfebrile fever. Symptoms usually appear 6-8 hours after pathogenic factor impact. In acute erosive gastritis, typically the patient is too ill to complain of noticeable gastric symptoms, which, if they are present, are usually mild and non-specific. The first obvious sign may be blood in the gastric aspirate, usually within 2 to 5 days of the major initial stress. Acute stress gastritis is diagnosed endoscopically. In certain patients, for example, those with burns, shock, sepsis, acute erosions may be seen as soon as 12 hours after the initial insult. The lesions may progress to invade the submucosa and even perforate the serosa, or more commonly may bleed, usually from multiple sites in the corpus of stomach. This slide illustrates numerous discrete round erosions with white exudate in the antrum of the stomach. This mucosal injury was caused by non-steroidal anti-inflammatory drugs. This is erosions, white with blood streaks, bleeding. That's all about acute gastritis. Now about chronic gastritis. Chronic gastritis is a chronic inflammatory disease of the stomach, accompanying with restructuring of its mucosa down to an atrophy, with inflammatory reaction of a stroma and disorders of secretory, motor, and other functions of the stomach. Etiology of chronic gastritis. There are two most common clinical etiological variants of the chronic gastritis. Chronic gastritis A is autoimmune, and chronic gastritis B is a Helicobacter pylori associated. Clinical picture. The clinical pattern of a chronic gastritis is characterized by three basic groups of the symptoms. The main symptom is pain, It may be accompanied by dyspeptic and asthenoneurotic syndromes, which depend on increased or diminished secretory function of the stomach. The signs of chronic gastritis are difficult to describe because the cause and symptomology of the disease are quite variable. Some patients don't complain of anything during remissions. The disease may also develop for a long time without any manifestations, and it is therefore difficult to establish the time of its onset. So chronic gastritis is also divided into chronic erosive gastritis and chronic non-erosive or atrophic gastritis. For the first, about chronic erosive gastritis. This condition is defined by the presence of multiply punctured or aphthous ulcers on endoscopy. Chronic erosive gastritis may be idiopathic or caused by drugs, especially non-steroid anti-inflammatory drugs. It may be a symptom of Crohn's disease or viral infections, but Helicobacter pylori does not play a role in pathogenesis of chronic erosive gastritis. Symptoms are non-specific and may include nausea, vomiting, epigastric discomfort. Some patients may be symptom-free. Endoscopically punctuate erosions are reviewed most frequently on the ridges of thickened rugal folds, often with a central white plaque or umbilication. Histologically, the degree of inflammation varies. No therapy is universal for this type of gastritis, and treatment is largely symptomatic, and the most important is to avoid non-steroid anti-inflammatory drugs. Non-erosive gastritis. There are two main types of non-erosive gastritis. First, Helicobacter associated, or type B. Helicobacter is increasingly implicated as the primary cause of non-erosive gastritis. This spiral-shaped gram-negative organism causes almost all cases of non-erosive gastritis and its resultant complications such as ulcer disease. Infection invariably leads to gastric mucosal inflammation, which in turn alters gastric secretory physiology, leaving the mucosa more susceptible to damage by acid. Highest concentrations of Helicobacter pylori are detected in the antrum, where confined infection substantially increases the risk of prepyloric and duodenal ulceration. In some patients, infection involves the entire stomach and appears to be associated with subsequent development of gastric ulcers and gastric adenocarcinoma. The second type of non-erosive gastritis is autoimmune, which is associated with HLA system, human leukocyte antigen system, and some other autoimmune diseases. So in case of autoimmune gastritis, there are anti-intrinsic factor antibodies and antiparietal cells antibodies. As a result, inhibition of gastric acid secretion and deficit of vitamin B12 develop in these patients. Symptoms and signs. Chronic gastritis may be asymptomatic. Clinical picture is characterized by following signs. The main complaint will be pain in epigastric area. It is mild expressed and vagally localized. Dyspeptic manifestations such as fullness, sensation in epigastric area linked with meals, belching, nausea, vomiting, appetite disturbance, bloating, rumbling, flatulence, and unstable stool. Clinical manifestations of gastritis depends on secretory function, and there are two main types of gastritis with normal or increased secretory function. It is characteristic for type B or Helicobacter pylori associated gastritis. In this case, patients will have sore belching, heaviness or dull aching pains in epigastrium after meals. Sometimes pains may awaken patient at night, and tendency to constipations. Another type of gastritis is characterized by secretory insufficiency. It is type A or autoimmune gastritis, and in this case the complaints will be fullness, sensation, and dull pains in epigastric area, nausea, poor appetite, obnoxious taste in the mouth, routine belching, rumbling, tendency to diarrheas. And besides of these symptoms will be symptoms of hypovitaminosis because of disturbance of absorption of different vitamins, proteins. So in this case, patients will have dry skin, angular stomatitis, and nails changes. And sometimes patients may have dumping syndrome, which is characterized by weakness, diaphoresis, dizziness, and palpitation appearance after meals. How to make a diagnosis? Non-erosive gastritis is suspected by symptoms but diagnosed by endoscopy and biopsy. Most patients with Helicobacter pylori associated gastritis are asymptomatic. So we need to detect Helicobacter pylori. There are non-invasive and invasive techniques for detecting of Helicobacter pylori. Non-invasive testing includes serological testing for immunoglobulins, anti-Helicobacter pylori immunoglobulins. Non-invasive testing also includes urea breath tests, and invasive testing requires gastroscopy and mucosal biopsy and should be reserved for patients with a prior indication for an endoscopy. Histological staining of gastric mucosal biopsies has a sensitivity and specificity more than 90%. Because it is accurate, easy to perform, and relatively inexpensive, so this testing should be considered the invasive diagnostic method of choice. About autoimmune atrophic gastritis. So to make a diagnosis of autoimmune atrophic gastritis, we need testing and detecting of anti-intrinsic factor antibodies, antiparietal cells antibodies for the first. Then we may assay serum gastrin and serum pepsinogen. In case of autoimmune atrophic gastritis, serum gastrin will be increased and serum pepsinogen will be decreased. And we need complete blood count. Incomplete blood count in case of autoimmune atrophic gastritis, we will detect iron deficiency anemia or perniciosus anemia. Perniciosus means macrocytic and hyperchromic due to disturbance of absorption of B12 vitamin. And patients with autoimmune atrophic gastritis may have symmetrical neuropathy predominantly affecting lower limbs because vitamin B12 plays role in lipids in metabolism in nervous system. That is why these patients may have weakness, paraplegia, paresthesia, ataxia, loss of position and vibration sense, spasticity, and clonus. This table shows the difference between autoimmune and Helicobacter pylori gastritis. So they have a difference in etiology. In affected areas, autoimmune gastritis affects body fundus of stomach, and Helicobacter pylori predominantly antrum of stomach. Key mechanism of pathogenesis. In case of autoimmune gastritis, the most important is hypochlorhydria and increased gastrin. And in case of Helicobacter pylori gastritis, the main aggressive factor will be urease production by Helicobacter pylori. Clinical presentation. In case of autoimmune gastritis, most patients may be asymptomatic, maybe symptoms of vitamin deficiencies, B12 and iron deficiency, and malabsorption. Malabsorption will characterized by diarrhea. In case of Helicobacter pylori, the main symptom will be pain in epigastric region. And complications of autoimmune gastritis will be anemia, iron deficiency or pernicious anemia, and carcinoid tumors. In case of Helicobacter pylori, the complication may be peptic ulcer and maltoma, mucus-associated lymphoid tissue lymphomas. So this is the difference between these two types of gastritis. Treatment. The main principles of treatment. For the first, remove offending agents such as non-steroid anti-inflammatory drugs. If it is Helicobacter pylori associated gastritis, we must apply eradicative therapy. We must eliminate Helicobacter pylori. We may use triple therapy or quadruple therapy. This therapy includes proton pump inhibitors, antibiotics, and if it is quadruple therapy, bismuth. In case of autoimmune atrophic gastritis, there is no specific tropic therapy. The therapy is only symptomatic. So for the first, we must correct vitamin deficiency, vitamin B12 deficiency or iron deficiency. Next, we will talk about peptic ulcer disease. Peptic ulcer is an excoriated segment of the mucosa, typically in the stomach, gastric ulcer, or first few centimeters of the duodenal ulcer, which penetrates through the muscularis mucosa. Ulcers may range in size from several millimeters to several centimeters. All ulcers are delineated from erosions by the depth of penetration. This is very important idea. Erosions are more superficial and don't involve the muscularis mucosa. This is the difference between ulcer and erosion. Etiology and pathogenesis. Peptic ulcer disease development is caused by imbalance between aggressive factors impacting and defense mechanisms providing integrity of gastric mucosa. So aggressive factors are hydrochloric acid, pepsin, bile acids, Helicobacter pylori infection, non-steroid and anti-inflammatory drugs, alcohol, stress maybe, smoking also plays role, dietary such as spicy food So defense mechanisms include mucobicarbonate barrier, prostaglandins, permanent mucous cell repair, availability of diverticated microvascular net. So immune disorders, chronic inflammatory infiltration of gastric mucosa, gastrin hypersecretion accompanying Helicobacter pylori infection have defined importance. And of course, hereditary also plays a role in ulcer disease development, and genetic factors also plays a role in development of ulcer disease. Classification of peptic ulcers. According to localization, they may be gastric ulcers. According to localization in stomach, it may be cardial ulcer, subcardial, ulcer of lesser curvatura, ulcer of great curvatura, or antral ulcer, and so on. Duodenal ulcer, and according to the stage of disease, it may be exacerbation or remission, and according to complications, may be bleeding, penetrating, malignance, or outlet stenosis, and so on. Symptoms. Symptoms depends on ulcer location and patient age. Many patients, particularly the elderly, have few or even no symptoms. But the most important symptom is pain in epigastric region. It often revealed by food, milk intake, for example, or antacids. The pain is described as burning or hunger pain. Usually this pain appears 30-40 minutes after meal, may radiate to the back, spine, especially ulcer of gastric posterior wall. The cause is usually chronic and recurrent. So this description of pain onset is characteristic for stomach ulcer. As for duodenal ulcer, pain onset tends to be consistent. Pain is absent when the patient awakens but appears in the middle morning. It is revealed by food but recurs 2 or 3 hours after meal, and the pain may awaken the patient at night. So this is the difference between stomach ulcer pain onset and duodenal ulcer pain onset. On the height of pain onset, vomiting of soft gastric contents relieve the pain. Erucation, regurgitation, salivation are frequent symptoms. Appetite is often increased, but patients are afraid of food intake because food intake after food intake they feel pain. That is why they restrict the meals they're eating, and this symptom is called cetophobia. The intestinal symptoms of peptic ulcer disease are constipation, which are closely connected with character of nutrition, bad rest during exacerbation, and are mainly connected with reflex dyskinesia of the small and large intestine. Heartburn. Heartburn is encountered in 60-85% of patients. It occurs not only during exacerbations, but can also precede exacerbation for several years. It can be periodic or seasonal. The mechanisms of heartburn is associated with motor dysfunction of the esophagus, in addition to the acid factor of the gastric contents, which was formerly believed to be decisive. It is very important to pay attention on history of disease and past life. The history of disease and past life shows the seasonal character of pain. It is very important characteristic of ulcer disease. Seasonal character of pain, it means that exacerbations are in spring and in autumn. Past life also shows irregular food intake, smoking, physical and emotional stress, and family predisposition to the disease. On inspection, the skin and mucous membranes may be pale after hemorrhage. On examination, coated tongue is usually revealed. Inspection of abdomen. The configuration of abdomen is normal. On abdominal palpation, tenderness in epigastric area or in Chafar's zone may be disclosed. During exacerbations, the epigastric region is tended to surface palpation. If the peritoneum is involved, may be positive Mendel test. In the presence of pyloric stenosis, peristaltic and antiperistaltic movements of the epigastrium can be seen. Brown pigmentation develops on the abdomen after prolonged application of warmer. Late splashing sound to the right of the median line, so-called Vasilenko symptom, indicates gastric evacuatory dysfunction or increased secretion between meals. Diagnosis. For the first, a complete blood count may show us anemia after bleeding. Positive test on occult blood infections may be after hemorrhage. The main method of diagnosing is gastroduodenoscopy. We also may use double contrast barium X-ray in some cases. And of course, we need detection of Helicobacter pylori infection, because the main causative factor of ulcer disease is Helicobacter pylori infection. Gastric secretory function. We may assess the gastric secretory function if the ulcer is found in the stomach. Hydrochloric acid and pepsin of the gastric juice vary within normal limits. In case of duodenal ulcer, all these indices significantly exceed normal values. Hypersecretion of the gastric juice is determined in this case by hypersensitivity of the vagus, intensified adrenal function, and increased quantity and hypersensitivity of the parietal cells. Study of the basal secretion of a fasting stomach is very important for the diagnosing of duodenal ulcer. So this slide demonstrates the ulcer lesion with hemorrhage, the stomach ulcer. Another example of ulcer of duodenum. This lesion is coated by fibrin. Next example, stomach ulcer coated with fibrin. And double contrast barium X-ray. This is the symptom of ulcer, a crater filled by barium. Another example, also crater filled with barium, a symptom of gastric ulcer. Complications of ulcer disease. For the first, hemorrhage. Hemorrhage is the most common complication of peptic ulcer disease. Symptoms include local symptoms and general symptoms. Local symptoms are vomiting with coffee ground material. If we've got passage of bloody or black tarry stools, it is called meliana. General symptoms are weakness, orthostasis, syncope, sweating, collapse maybe, These symptoms are caused by blood loss. Next complication, penetration, confined penetration. A peptic ulcer may penetrate the wall of the stomach or duodenum and enter the adjacent confined space, for example, leather sac or organ, for example, pancreas or liver. Adhesions prevent leakage into the free peritoneal cavity. Pain may be intense, persistent, referred to sites other than the abdomen, usually the back, when caused by penetration of a posterior duodenal ulcer into the pancreas, and modified by body position. The main method of diagnosing this complication is computer scanning. And when medical therapy does not produce healing, surgery is required. The next complication, free perforation. Free perforation usually presents as an acute abdomen syndrome. Ulcers that perforate the peritoneal cavity are usually located in the anterior wall of the duodenum or less commonly in the stomach. The patient experiences sudden, intense, steady epigastric pain that spreads rapidly throughout the abdomen, often becoming prominent in the right lower quadrant and at times referred to one or both shoulders. The patient usually lies still because even deep breathing can worsen the pain. Palpation of the abdomen is painful. Rebound tenderness test is positive, or another name of this test, Schottky-Blumberg sign, positive. Please revise how to check this symptom, how to perform rebound tenderness test from the previous semester. Also, abdominal muscles are rigid, board-like, and the bowel sounds are diminished or absent. Symptoms may be less striking in the elderly, the moribund, and those receiving corticosteroids or immunosuppressants. Diagnosing is confirmed if an upright or a lateral decubitus X-ray of the abdomen shows free air under the diaphragm or in the peritoneal cavity. This X-ray demonstrates the pneumoperitoneum. It is pointed, so under diaphragm we see free air. This is a symptom of free perforation. Gastric outlet obstruction, the next complication of ulcer disease. They may be caused by scarring, spasm, or inflammation associated with an ulcer. Symptoms include recurrent large volume vomiting occurring more frequently at the end of the day and often as late as 6 hours after the last meal. Persistent bloating or fullness after eating and loss of appetite also suggest gastric outlet obstruction. Prolonged vomiting may cause weight loss, dehydration, and alkalosis. This complication is detected by double barium X-ray by pointed the gastric outlet obstruction on X-ray. And the last complication, stomach cancer. Helicobacter pylori is associated with intestinal type adenocarcinoma of the gastric body and antrum, but not cancer of the gastric cardium. Infected persons are 3 to 6 times more likely to develop stomach cancer. There are no data to suggest that eradicating Helicobacter pylori prevents progression of gastritis to more common cancer or lymphomas of the stomach. Therefore, there is no scientific reason to diagnose and treat Helicobacter pylori to prevent malignant complications. So we use X-ray, endoscopy, biopsy, to make a diagnosis of stomach cancer. This is an example of X-ray in case of stomach ulcer. This is stomach ulcer. And this is endoscopy of stomach ulcer, stomach cancer, sorry. This is stomach cancer. So that's all about gastritis and ulcer disease, and now we are going to talk about hepatitis and cirrhosis. We will talk about chronic hepatitis only, because acute hepatitis is infectious disease, which etiology is viruses. So you will talk about acute hepatitis on the cause of infectious disease. And we will talk about chronic hepatitis. Chronic hepatitis represents a series of liver disorders of varying causes and severity in which hepatic inflammation and necrosis continue for at least 6 months. So if hepatitis presents more than 6 months, it is chronic. Less than 6 months, it is acute. Etiology of chronic hepatitis. For the first infectious viruses of hepatitis B, C, D, herpes virus, for example, tuberculosis, AIDS, and some others. The next very important and common cause of chronic hepatitis, different poisoning, chronic poisoning, such as alcohol or drug intake, industrial poisons. Next cause, next type of chronic hepatitis, toxic allergic. It also may be medicamentosus, or it is hepatitis associated with systemic diseases of connective tissue. Next type of chronic hepatitis is metabolic. Metabolic hepatitis is associated with protein and vitamin deficiency or fat dystrophy. The next, hereditary predisposition, such as alpha-1 antitrypsin deficiency. Next type, autoimmune chronic hepatitis. Next type, cholestatic hepatitis, which develops in case of cholelithiasis, for example. And the last, idiopathic or cryptogenic hepatitis, when we don't know etiology, without known etiology. Pathogenesis of chronic hepatitis. The mechanism of chronicity of is uncertain, but a direct cytopathic effect of the virus appears to be only minor, especially with hepatitis B viral infection. Instead, the liver injury is largely caused by an immune-mediated host reaction to the infection. The pathogenesis varies with drug, and many reflect an altered immune response, cytotoxic intermediate metabolites, or genetically determined metabolic defects. Many causes are idiopathic. A high proportion of these causes have prominent immune features. This is considered a specific variant of the disorder, autoimmune hepatitis. Classification of chronic hepatitis. So according to the cause, the most common etiological variants: chronic viral hepatitis B, C, D, autoimmune hepatitis, drug-associated chronic hepatitis, and cryptogenic chronic hepatitis. According to the grade histological assessment of necroinflammatory activity, it may be portal inflammation or minimal activity hepatitis, periportal necrosis or moderate activity hepatitis, bridging necrosis or severe activity of hepatitis. According to the stage is based on the degree of fibrosis. 0 stage, no fibrosis, from 1 to 3 different type of fibrosis: mild, moderate, and severe, and the last is cirrhosis. According to clinical variants, chronic hepatitis may be chronic persistent bearing hepatitis, chronic active or aggressive hepatitis, chronic autoimmune, and chronic cholestatic hepatitis. Symptoms. Clinical features vary. About 1/3 of cases follow acute hepatitis, for example, acute viral hepatitis, but most develop insidiously de novo. Many patients are asymptomatic, especially in chronic hepatitis C. Chronic hepatitis is characterized by, first, biliary dyspepsia, jaundice, it may be absent in some cases, moderate enlargement and induration of the liver and spleen, hepatosplenomegaly, this symptom is called, astenoneurotic syndrome, which is characterized by non-specific malaise, anorexia, fatigue, sometimes low-grade fever, and the last, dysfunction of the liver, which is determined by laboratory tests. Various degree of one or several biochemical syndromes. These syndromes are cytolysis, cholestasis, mesenchymal inflammation, and hepatocellular insufficiency. So we have talked about these syndromes, about jaundice, hepatic type of jaundice, about all these syndromes previous semester. The clinical picture and also the cause of each clinical morphological form of hepatitis have their special features, but these 5 are common and general. So let's revise your knowledge about clinical biochemical syndromes in case of chronic hepatitis. So the first biochemical syndrome of liver pathology is hepatocellular insufficiency. This syndrome is characterized by decreased concentration in the blood of substances which are synthesized by hepatocytes. So in this case, serum albumins, cholesterol, prothrombin, proconvertin, fibrinogen, and serum cholinesterase will be decreased. Next syndrome, cholestasis. Cholestasis is an increased concentration in blood of substances exerted in bile by hepatocytes. So in case of cholestasis, cholesterol, bile acids, bound or direct or conjugated bilirubin, alkaline phosphatase, gamma-glutamyl transpeptidase, and copper will be increased. Next syndrome, cytolysis, is an increased concentration in blood of cytoplasmatic enzymes of hepatocytes due to necrosis of hepatocytes, due to damage of hepatocytes. There is why aspartate aminotransferase AST, alanine aminotransferase ALT, lactic dehydrogenase, its fifth fraction, and gamma glutamyl transpeptidase will be increased. And the last biochemical syndrome, mesenchymal inflammation. Mesenchymal inflammation is an increased content of various globulin fractions produced by reticulohistiocytoid cells of liver. So in this case, globulins, alpha, beta, gamma globulins will be increased. Turbidity test will be positive. This test detects the ratio between globulins and albumins. So in case of increased globulins and decreased albumins due to hepatocellular insufficiency, this test will be increased and will be positive. And erythrocyte sedimentation rate acceleration is also a symptom of mesenchymal inflammation syndrome. So this is the clinical presentation of clinical and laboratory presentation of chronic hepatitis. On a general inspection, when we perform general inspection of the patients with chronic hepatitis, we will detect moderate enlargement and induration of the liver and the spleen. And your task, your home task for this class, the class about hepatitis and cirrhosis, will be to revise your knowledge about liver palpation and liver percussion. So you must repeat how to perform percussion, liver and spleen, and what are the normal sizes of liver and the spleen. What are the normal characteristics of liver and spleen? Some words about treatment. Treatment includes sessions of causative drugs and management of complications such as ascites and encephalopathy. Autoimmune hepatitis is best treated by corticosteroids with or without azathioprine. Azathioprine is immunosuppressant. These drugs suppress the inflammatory reaction, perhaps partially by beneficially altering the immune response, and have increased long-term survival. Therapy of chronic hepatitis B and C is evolving. Corticosteroids are contradicted because viral replication is enhanced. Interferon is now widely used to suppress viral replication. Next, we will talk about cirrhosis. Cirrhosis is diffuse disorganization of normal hepatic structure by regenerative nodules that are surrounded by fibrotic tissue. The nodules typically contain liver cell plates, 2 to 4 cell thick and sparsely placed venules. The pathological changes in cirrhosis generally involve the entire liver. Extensive fibrosis, even with regenerating nodules, is usually irreversible, although fibrosis in animals can resolve depending on experimental design. In humans, cirrhotic damage is permanent. Nodal regeneration is a vain attempt at repair. Etiology of cirrhosis is similar to that of chronic hepatitis. So infection, toxins, altered immune response, biliary obstruction, and vascular disturbance. Hepatitis C and other forms of chronic hepatitis, from autoimmune chronic active hepatitis and certain drugs, result in cirrhosis. Metabolic causes include hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, galactosemia and congressional teratosis. Even diabetes mellitus has been associated with development of cirrhosis. Prolonged biliary obstruction, so-called secondary biliary cirrhosis. Chronic venous outflow obstruction, for example, Budd-Chiari symptom, and malnutrition can lead to cirrhosis. Sometimes cirrhosis may be of unknown etiology. It is termed cryptogenic. Pathogenesis. So cirrhosis is the end stage of many forms of liver injury, characterized initially by fibrosis. The progression of fibrosis to cirrhosis and the morphology of cirrhosis depend on the extent of injury, presence of continuing damage, and the response of the liver to the damage. Cirrhosis is related not so much to the injurious agents as to the kind of injury and the liver's response to it. The liver may be injured actually and severely, as in submassive necrosis with hepatitis, moderately over months or years, as in case of biliary tract obstruction or chronic hepatitis, or modestly by continuously, as in alcohol abuse. Cytokines and hepatic growth factors are presumably responsible for the response to injury. So fibrosis plus regenerating nodules. During the repair process, new vessels form within the fibrous sheath that surrounds the surviving nodules of liver cells. These bridges connect the hepatic artery and portal vein to the hepatic venous, restoring the intrahepatic circulatory pathway. Such interconnecting vessels receive blood from the sinusoid and provide relatively low volume, high pressure drainage that is less efficient than normal and results in increased portal vein pressure, portal hypertension development. Disordered blood flow to the nodules and compression of hepatic venous by regenerating nodules also contribute to portal hypertension. So it means that portal hypertension is one of the most common and one of the most general symptoms of cirrhosis. So symptoms and signs of cirrhosis. Clinical manifestations of liver cirrhosis depend on the degree of affection of the liver cells and the associated hepatic dysfunction and portal hypertension, on the stage of the disease, compensated to decompensated, and also on the activity of the process. The following syndromes of the disease are most characteristic of the majority of patients with various forms of liver cirrhosis. So the first symptom will be hepatosplenomegaly. The next, portal hypertension with variceal bleeding and ascites. The next, portal systemic encephalopathy. Next syndrome, hypersplenism. Next, hepatic insufficiency. And last, hepatic jaundice. So clinical presentation of cirrhosis will be combination of these syndromes. Many patients with cirrhosis may be asymptomatic for many years. Others show generalized weakness, anorexia, malaise, weight loss. With obstruction to bile flow, jaundice, pruritus, and xanthelisms become prominent. Fever is usually irregular, and sometimes of the indolent type. Marked fever is characteristic of the active period of infectious cirrhosis. Pain may be in the region of the liver, in the epigastrium, or diffuse pain in the whole abdomen. It is usually dull and boring, intensifying after meals, especially after fatty food, implied drinking and physical exercise. Pain is usually associated with enlargement of the liver and distension of the capsule of the liver, or with necrotic fats located near the capsule, with perihepatic symptoms and also concurrent inflammatory affections of the bile ducts. The next, dyspepsia in the form of decreased appetite to complete anorexia, the feeling of heaviness in the epigastrium after meals, nausea, vomiting, meteorism, and dyspeptic stools, diarrhea especially after fatty meals, rarely constipation, depend mainly on deranged secretion of bile and hence defective digestion. The intensity of jaundice varies from light subicteric to marked jaundice depending on the degree of obstruction of the bile ducts. Jaundice is usually characterized by partial decoloration of feces and by the presence of bile in the duodenal contents. Jaundice is often attended by skin itching and associated with biliary cirrhosis, resembles obstructive jaundice. Severe skin itching and xanthelasms may be observed. On palpation, on liver palpation, the liver is firm, palpable with a blunt edge, but at times the liver is small and difficult to palpate. Regenerating nodules may be occasionally palpable. The next symptom on general inspection is ascites presence. Ascites is a symptom of portal hypertension. It may be accompanied by splenomegaly and collateral venous circulation. So from previous semester you must revise your knowledge how to assess ascites. The methods of ascites assessing. Hemorrhage syndrome also may be observed in near 15% of patients with liver cirrhosis. Profuse bleeding from varices veins of the esophagus and the stomach can often be early symptom of portal cirrhosis and the symptom of portal hypertension. Gastrointestinal hemorrhage, vomiting with coffee grounds and melena stool is caused by the rupture of varices nodules in the lower third of esophagus or less frequently in the stomach. A direct cause of varices hemorrhage is physical strain or local affection of the mucosa, for example by coarse food. And patients may be nasal, gum, uterine, and skin hemorrhages. They depend on the decreased coagulability of blood due to liver dysfunction and thrombocytopenia. So different types of hemorrhages will be a symptom of hepatic insufficiency syndrome and the syndrome of hypersplenism. Hypersplenism means increased function of spleen. You know that spleen plays a role in destruction of cells, of blood cells, including thrombocytes. So thrombocytopenia is caused by increased destruction function of the spleen. minor clinical signs of cirrhosis on general inspection. So on general inspection we may find spider angiomas, or they are called skin teleangioectasia. They may develop years before marked symptoms of the disease development, and less than 10 teleangioectasia, this is normal. So if they more, it is abnormal. Their number increases in the color intensifies during exacerbations of the disease. The next minor clinical symptom is called palmar erythema. It is red colored of tenor and hypotenor. Next symptom, red lustrous lips, scarlet mucus of the mouth, and scarlet tongue, so-called hepatic tongue. Next symptom, gynecomastia, increased mammary glands and other female sex characteristics developing in men, decreasing growth of hair on the face, chest, abdomen, and the head, axillary hair loss, testicular atrophy. This symptom is connected with decreased destruction of estrogens in liver due to liver insufficiency. Next symptom, xanthomas and xanthelasms. They are observed in patients with biliary cirrhosis of the liver. And the last, hypocratic or clubbed fingers with hyperemic skin and the nail beds and watch glass nails. So this is examples of xanthelasms, lipid deposits, lipid plaques in the angle of the eye. This is palmar erythema, hyperemia, red color of tenor and hypotenor. Jaundice, jaundice of the skin, mucous membranes, gynecomastia in male, spider nevi or xanthelasms. This is also example of spider nevi, numerous spider nevi and very large, and finger clubbing. This is the symptom of portal hypertension syndrome, caput medusae, or dilated collateral veins of anterior abdominal wall. Ascites, enlarged abdomen with prominent umbilicus. So, diagnosis of cirrhosis. Routine laboratory tests of liver function may be normal in cirrhosis. Biochemical blood analysis show dysfunction of the liver as determined by laboratory tests, various degree of one or several biochemical syndromes, cytolysis, cholestasis, mesenchymal inflammation, hepatocellular insufficiency, and hepatocellular jaundice. We have discussed them. Then incomplete blood count anemia may be. As a rule, it is normocytic anemia, but sometimes it may be microcytic and hypochronic from chronic gastrointestinal bleeding, or it may be macrocytic from folate deficiency in case of alcohol abuse, or it may be hemolytic when the patient has hypersplenism syndrome. Hypersplenism also leads to leukopenia and thrombocytopenia, and when patient has decreased erythrocytes, erythrocytopenia, leukopenia, and thrombocytopenia, decreased amount of leukocytes and thrombocytes, it is called pancytopenia, And once again, the cause of pancytopenia is increased function of spleen, and spleen plays role in destruction of blood cells. Next, we may use ultrasound. Ultrasound may reveal textural abnormalities suggestive of cirrhosis, confirm hepatosplenomegaly, and detect features of portal hypertension, such as enlargement or obstruction of the portal and splenic veins and presence of esophageal varices. Then Doppler ultrasound can demonstrate portal blood flow and measure pressure in portal vein. Computer tomography better evaluates liver size and texture and density of the liver. And endoscopy is best for diagnosing of esophageal varices and esophageal bleeding. Treatment. In general, treatment of cirrhosis is suppurative, withdrawal of toxic agents, attention to nutrition, and treatment of complications as they arise. And liver transplantation for patients with advanced cirrhosis. Next, our theme, chronic cholelithiasis. Pathologically, a thick-walled fibrotic contracted gallbladder. Clinically, chronic gallbladder disease characterized by symptoms that include recurrent colic, hepatic colic. The mucosa may be ulcerated and scarred, and the lumen may contain sludge or stones, gallbladder stones, that often obstruct the cystic duct. Formation or presence of calculi, gallstones, in the gallbladder means cholelithiasis, and most clinical disorders of the extrahepatic biliary tract are related to gallstones. Factors that increase the probability of gallstones include female sex, obesity, increased age, a Western diet, and a positive family history. Symptoms. The clinical consequences of stone formation in the gallbladder are exceedingly variable. Most patients remain asymptomatic for long periods, frequently for life. But stones may traverse the cystic duct with or without symptoms of obstruction. Transient cystic duct obstruction results in colical pain, whereas persistent obstruction usually produces inflammation and acute cholecystitis. In contrast to the other types of colic, biliary colic typically is constant, with pain progressively rising to a plateau and falling gradually, lasting up to several hours. Nausea and vomiting are often associated. Fever and chills are absent in uncomplicated gallbladder colic. Pain most often occurs in epigastrium or right upper quadrant, radiating to the right lower scapula. Symptoms of dyspepsia and fatty food intolerance are often inaccurately ascribed to gallbladder disease. Belching, bloating, fullness, and nausea are associated about equally with cholelithiasis, peptic ulcer disease, or functional distress. Such symptoms may disappear after cholecystectomy, but should not be the only indication for operation. Postprandial fatty food intolerance is likely to be caused by cholelithiasis if symptoms include right upper quadrant pain. However, the prevalence of postprandial functional distress is so high in the general population that symptoms alone are insufficient for diagnosis of gallbladder disease without separative clinical signs and diagnostic studies. So what are the symptoms, gallbladder symptoms, which will be positive in case of cholelithiasis, acute cholecystitis, or exacerbation of chronic cholecystitis? They are the first Murphy's symptom. This is the description how to perform this test. So during the inspiration, the examiner's finger positioned along the inferior body of the liver in the right costal arch, and we press during inspiration of the patient. If patient feels pain, the symptom is considered to be positive, and it is a symptom of acute cholecystitis. This is enlarged gallbladder, so normally we can't palpate and we can't observe gallbladder, but if we can palpate it in a patient with jaundice, this symptom is called Courvoisier-Terrier symptom, and this is the symptom of malignancy of gallbladder. Next gallbladder symptom, or symptom of acute cholelithiasis or cholecystitis, Kerri symptom, is a significant increase of sensitivity to pain on inspiration during palpation of gallbladder with the thumb of the right hand. Next symptom, Kerte symptom, pain and tension of the abdominal muscles of epigastric region and left hypochondrium, or in the place of projection of pancreas. This symptom will be positive in case of acute pancreatitis. Vasilenko symptom, tenderness to percussion in the projection point of gallbladder at the height of inspiration. Musi-Georgievsky symptom, pain that worsens when pressed between the legs of the sternocleidomastoidus muscle at the upper edge of the clavicle at the right side. Next symptom, Ortner-Grekov symptom, pain that occurs when beating the edge of hand on the right costal arch with breath of the patient on inspiration. This symptom may be positive in acute cholecystitis and hepatitis and cirrhosis. How to make a diagnosis of cholelithiasis? We may perform X-ray, but most of gallstones are not visible on X-ray. Only about 10% of gallstones contain enough calcium to be visible, like on this X-ray. That is why the most important method is ultrasound. Nowadays, this is the most important method for diagnosing of gallstones. So this is gallbladder. This is white is gallstone. Sometimes we need complete blood count. In complete blood count, we will detect inflammatory changes. Inflammatory changes are increased white blood cells count, increased neutrophils, left shift of neutrophils, and accelerated erythrocyte sedimentation rate. Biochemical analysis. In biochemical analysis, we will detect increased direct bilirubin or conjugated bilirubin, and increased alkaline phosphatase. So it means that cholelithiasis is characterized by presence of post-hepatic jaundice or cholestasis syndrome. So these two laboratory syndromes may be characteristic for cholelithiasis. Inflammation of the pancreas is called pancreatitis. Pancreatitis is classified as either acute or chronic. Acute pancreatitis refers to an acute inflammation that resolves both clinically and histologically. Chronic pancreatitis is characterized by histological changes that persist even after the cause has been removed. The histological changes in chronic pancreatitis are irreversible and tend to progress, resulting in serious loss of exocrine and endocrine pancreatic function and deterioration of pancreatic structure. Causes of pancreatitis. The first, biliary tract diseases and alcoholism account for more than 80% of hospital admissions for acute pancreatitis. So two main causes, alcohol consumption and biliary tract diseases such as cholelithiasis. The remaining 20% are attributed to drugs, estrogen use, hypertriglyceridemia, and endoscopic retrograde pancreatography. Pancreatitis may be connected with structural abnormalities of pancreatic duct, for example, cancer or stricture, structural abnormalities of the common bile duct, surgery, vascular diseases, especially severe hypertension, blunt and penetrating abdominal trauma, hyperparathyroidism and hypercalcemia, renal transplantation, hereditary pancreatitis. Etiology and pathogenesis. Chronic pancreatitis most commonly results from alcoholism and idiopathic causes. Similar to acute pancreatitis, microlithiasis has been implicated in some cases of chronic pancreatitis. Rare causes are hereditary, hyperparathyroidism, and obstruction of the main pancreatic duct caused by stenosis, stones, or cancer. Rarely severe acute pancreatitis causes sufficient pancreatic ductal stenosis to impair drainage and result in chronic pancreatitis. In India, Indonesia, and Nigeria, idiopathic calcific pancreatitis occurs among children and young adults. Symptoms. The first and the main symptom is pain. Although there is occasionally no pain, severe epigastric pain may last many hours or several days. Possible causes include acute inflammation not recognized by conventional tests, distension of pancreatic ducts caused by strictures or calculi, pseudocysts, perineural inflammation, or obstruction of either the duodenum or common bile duct caused by fibrosis of the head of the pancreas. Pain appears early enough in inflammatory process location in the pancreatic head. Area pains are felt mainly in the right epigastrium, right hypochondrium, radiate to the area of from 6 to 9 thoracic vertebrae. In pancreatic body involvement, pains are localized in the epigastrium. pancreatic tail in the left hypochondrium, and the pain radiates to the left and upwards from 6th thoracic up to the first lumbar vertebra. In total pancreas involvement, pains are localized in the whole of the abdominal upper half and have in girdling character. Mostly pains occur after abundant meals, particularly fatty, fried food, alcohol, and chocolate consumption. Often enough, pains appear on fasting or 3 hours after meal. That demands to differentiate from duodenal ulcer. Pains relief on starvation. So many patients eat a little and lose the weight. There is definite diurnal rhythm of pancreatic pains. In the morning they bother not much, but in the afternoon they increase or appear if they were absent therefore, and culminate in the evening. Pains may be constricting, burning, gnawing, significantly more pronounced in supine position and decrease in sitting position, leaning forward. In expressed exacerbation of chronic pancreatitis and severe pain syndrome, a patient takes forced sitting position with bended in knee joints and adducted to the abdomen legs. Dyspeptic syndrome. Pancreatic dyspepsia is characteristic enough of chronic pancreatitis. Particularly frequent, it is expressed in exacerbation or severe course of disease, and it involves salivation, air or eaten food irritation, nausea, vomiting, loss of appetite, fatty food intolerance, and flatulence. Weight loss may develop, and the severe pancreatitis may be accompanied by general weakness and dizziness. Pancreatic diarrhea and malabsorption and maldigestion syndrome are very characteristic of severe and protracted forms of chronic pancreatitis with pronounced impairment of pancreatic exocrine function. So for these syndromes is characteristic steatorrhea. It means passing of big amount of bulky, full-smelling pepper stools, greasy in appearance. In grave forms of chronic pancreatitis, malabsorption and maldigestion symptoms develop that leads to weight loss, dryness and damage of skin, hypovitaminosis, dehydration, electrolyte disbalance, fat steatorrhea, starch amylarrhea, and indigested muscular fibers, creatorrhea, are revealed in fats in the case of presence of these syndromes, malabsorption and maldigestion. And the last, incretory insufficiency is manifested as diabetes mellitus or impaired glucose tolerance. So the symptoms on general inspection are presented in lecture, which is published on Portal, because our time is over, and you may look through these symptoms in lecture, which is downloaded on Portal, and pay attention on laboratory findings in case of chronic pancreatitis. So serum amylase, urine amylase, and lipase will be increased in case of chronic pancreatitis. Stool trypsin and stool hemotrypsin will be decreased. So these findings are characterizing the exocrine insufficiency of pancreas.